So, as you know, I'm Peter Kern, the coordinator for this lecture series. And it's my privilege to introduce tonight's speaker, who is Genevieve Reid. Genevieve is a practicing family physician who lives in Livingston, Montana, and who drove here all the way from Livingston, Montana to give her lecture tonight. So it's great to see so many of you here, to have that opportunity to hear from Genevieve. Genevieve's worked in Pakistan, Nicaragua, Morocco, and Bolivia on women and child's health issues in remote, low-income settings. So I think you'd have to say that among all of the people who have spoken in this lecture series, she might have, maybe next to Nancy Fitch, the most countries to report on. Dr. Reid is the director of Global Midwife Education Foundation, an organization that works to train birth attendants, improve educational opportunities, and improve water and sanitation, especially in southern Bolivia. Please, she's going to talk tonight on maternal mortality in low-income countries. Please join me in welcoming Genevieve Reid all the way from Livingston. When I first put together the title for this lecture series, I thought we call it Western Montanans, or Mountains Beyond Mountains of Western Montanans. And then, because of Genevieve, I had to take the Western out of this.
Yep, we're on the eastern slope. And there's an announcement, and people in the human sexuality class need to pick one of these up. Anybody not get one? Okay. Can everybody hear me? Yep. More? I'll move it up. Is that better now? Yeah, okay, great. So where can I change the slides? Okay. I always start my talks with this slide. This is a photo of a mural on the wall of a birth center in Nicaragua, showing a woman dangling over the flames of childbirth. Huh? I don't know. Do you guys think it's dark enough? We can do it. Okay. So I'm going to talk about improving maternal survival in low-income settings and go over the socioeconomic causes of maternal mortality and some of the current interventions that are improving survival. This is a huge topic to cover in an hour, so really we're just going to do a quick overview of some of the key points in maternal mortality in low-income settings. So worldwide in 2010, I wonder if I could spin this over here so I don't have to walk back over there. In 2010, which is the most recent year that we have complete data for, 280,000 women died of pregnancy-related causes. And 90% of those deaths occurred in low and lower middle income countries. The World Bank organization gives us a definition of those countries, and so we're talking about, in this talk, we're talking about countries where the average person earns less than $4,000 a year. The World Health Organization is the organization that keeps track of maternal mortality in the countries around the world. It represents 194 countries in the world. All of those countries try to keep track of their own maternal mortality rates, and they report them to the World Health Organization. So the World Health Organization keeps track of those. They shape research, they set norms, they come up with evidence-based recommendations, and they monitor trends. A lot of the places that the World Health Organization is monitoring has people living in homes like this. It's very difficult to keep accurate track of statistics of maternal mortality when most of the women born in these areas don't have birth certificates. They also don't have death certificates. So a lot of what the World Health Organization uses are data that are collected when they have more intensive monitoring, such as in places of war, where they have more people on the ground. And then they use statistical analysis using countries that do take keep better track of their numbers and try and relate them to those countries where deaths are very underreported. And of course, the countries that we're talking about where 90% of the deaths occur are those countries that are very much underreporting their maternal mortality. This little baby's mom died of a postpartum hemorrhage, and grandma is going to raise her. So the World Health Organization came up with the Millennium Development Goals, and you guys have probably heard of the MDG 1, MDG 4 is for infant mortality, MDG 5 is maternal mortality. And the goal they set in 1990 was that we would have a 75% reduction in maternal mortality worldwide and for individual countries in the 25 years from 1990 to 2015. As of 2012, we've had about a 40% reduction in maternal deaths, which is huge. It's a huge reduction in 22 years. It is short of what the goal was, but it's more than halfway there, and it's been a huge reduction. Not waiting for 2015 to come, WHO and UNICEF has set another goal, and now the goal is by 2035, between 2010 and 2035, we're going to try and get maternal mortality to less than 70 maternal deaths per 100,000 live births, and that's the standard reporting measurement for maternal mortality. This is a typical map we see with maternal mortality. I'm going to show you a similar map for other problems. We see the darker pink in sub-Saharan Africa, in Afghanistan, Pakistan, India, and then Bolivia is often a little hot spot, along with Honduras and El Salvador, Guatemala. Here are some examples of some rates we see, remembering that 70 per 100,000. And this is also a similar graph to what you see between 1990 and 2010. Most countries around the world, especially in low and middle income countries, had a significant reduction of mortality. Bolivia, as an example, went from about 700 deaths per 100,000 down to about 300 deaths per 100,000. Afghanistan, that's the greatest effect of our war effort. Afghanistan is getting women prenatal and birth attendant care in Afghanistan. Somalia has had a rise, likely because of famine and more conflict, as has Chad and Nigeria. Ireland is the pattern that you see for most developed countries or wealthy countries in Western Europe, Canada, Australia. Most of them all have flat lines. The United States is an outlier. We've actually had a doubling of our maternal mortality rate from 12 to 24 in that period of time. Ireland, is around 4 to 6, as most countries in Scandinavia, Western Europe. So we're about 6 times as high as other similar income countries. Maternal mortality, the medical causes, does not vary much from country to country, from low income to wealthy. Really, if you look at almost any country from Somalia to Ireland, women die of these same problems in about the same proportions. You have a little bit more infections in low-income settings, and you have a little bit more hypertensive disease deaths in higher-income countries. But they come out to about that same ratio. You have more deaths from unsafe abortion in countries that outlaw abortion, of course. Other deaths, any death that occurs during a pregnancy is considered a maternal death. So, for example, deaths from diarrhea, pneumonia, HIV, tuberculosis, those all would fall in that category. So the point being, how does one country have 6 deaths per 100,000 and another have 600 per 100,000 when the diseases are the same? Mahmoud Fahala feels that this is really all due to socioeconomic causes. Women are not dying because we don't know how to treat postpartum hemorrhage. They're dying because their countries are not making the economic or social decisions to save their lives. So what are the socioeconomic causes of maternal mortality? I think everybody here would be able to predict most of these. It's poverty, race, rural location, lack of education, human rights violations, lack of clean water, sanitation, and lack of access to health care. So this woman exemplifies all of these things except for maybe human rights violations because she lives in Bolivia. She is a poor, indigenous woman who lives in a rural location. She does not speak Spanish, so all of her healthcare providers would speak Spanish, not Quechua. She is too far to walk to a healthcare provider. She has no communication. She has no access to contraception. She does not have clean water or sanitation. Thus, she delivered her 8th baby in her front yard with her husband helping her, and survived. Obviously, she was thriving. But the question is, how can we prevent this type of dangerous birth for women when so many of these factors are seemingly unchangeable? But are they? Okay. So poverty is probably one of the greatest risk factors for dying in childbirth. Currently, the rates of poverty are decreasing. And when we look at extreme poverty, $2.50 or less a day, corrected back to 1980, we've gone from about a 42% rate of extreme poverty to just a little under a 20% rate of extreme poverty. And then we have countries that are actively trying to intervene based on disparity. So this is a study that looked at the impact Brazil has made. Brazil went from a dictatorship in the 1980s to a democracy, and that democracy was very interested in reducing healthcare disparities. So you had a very engaged, active government who was funding healthcare. And in 10 years, from 1996 to 2006, looking at quintiles, poorest to richest, they were able to increase the rate of having a skilled birth attendant from 72% to 96% in just 10 years. And these are the poorest of the poor that they did that for. They increased antenatal care from 52 to 92%. They increased contraception use from 52 to 82% in a very Catholic country. And they increased piped water supplies from 34 to 75%. All the while maintaining the high rates that they already had in the wealthier quintiles. So this is an example of a government that is intentionally targeting poverty without correcting poverty itself, but making big impacts in healthcare disparity. Geographic isolation is another problem that's very hard to deal with because everybody can't come live in town or we wouldn't have any food supply. Along with geographic isolation is inadequate transportation. People who live in very remote areas are not the ones who have the great 4x4 cars to go through roads like this. Most people who live in geographic isolation in the world would have access to a truck like this usually once or twice a week that would take them to market, and it's not free. They have to pay to use it. Most of these roads, anywhere where it rains a lot, are only going to be accessible 10 to 6 months out of the year. And remember that map on maternal mortality? This is a map looking at road access. So 1 billion people currently live more than 2 kilometers from an all-season road. Not 2 kilometers from a market or a hospital, but 2 kilometers from an all-season road. This makes access to care very difficult. Girls' education, we talked about girls' education as being a big risk factor, lack of education as being a big risk factor for maternal mortality. A lot of countries and NGOs are trying to address the inequality of girls' education. But here's another map that looks very similar to the other ones, where we see concentrations of low girls' education rates in sub-Saharan Africa, again in India, Pakistan, Afghanistan, Bolivia. I don't know why Chile comes out high here. And then countries where more than a very high rate, more than 750 women die in pregnancy-related causes, being mostly clustered in these areas. Lots of studies by the World Health Organization, UNICEF, UNESCO have all shown very high rates of improvement in maternal mortality with minimal increases in education. So in Mali, women with secondary education, which is actually high school in Mali, have a 50% reduction in the number of babies they have. That equals a 50% reduction or more of death in childbirth, because you're having your opportunities to die in childbirth by having half the number of children. In Guatemala, each year a young woman spent in school delays childbirth 6 to 10 months. That's a huge number of births we're talking about when we talk about this multiplied by getting girls to stay in school for longer. In Burkina Faso, which is a country in Africa, mothers with secondary education are twice as likely to give birth in health facilities. Having a birth in a hospital versus a home birth in a poor income country reduces your chance of dying by about 4-fold. Couple more, because we come back to poverty, and if we increase girls' education, we also decrease their poverty. So comes around again, amplifying the gains. A single year of primary school increases the wages by 10 to 20%, and a year of secondary school increases it 15 to 25%. We're not talking about college as secondary school, just high school. The downstream effect is even greater when you look at the effect on babies. So women who go to school are more likely to vaccinate their children. 3 times more likely to vaccinate their children. And in Bangladesh, odds of having a child who is malnourished decreases 5% for every year of formal education. So if you send your kid to 10 years of school, it's a 50% reduction in malnutrition. I'm going to move on to talk about another cause tied to maternal mortality, and that's human rights. So obviously in this country we very much take our human rights for granted. This is an Amnesty International volunteer in Morocco. She is getting people registered with their government. As we said before, a lot of women do not have birth certificates. And if you don't have a birth certificate, in most countries you're not really a registered citizen. How does the government know you're there if you don't have an ID number or registration? So these volunteers go into rural areas and they register women with their own government, and thereby giving women the right to access health care, the right to own property, all the other rights that a citizen would have. Interesting story that I had from traveling in Morocco. A lot of the women there, they do have some health facilities, but very few of the women there would access the health facilities to have their babies. Talking to the women about why they wouldn't access those health facilities. The story I heard over and over again is, well, if a woman dies in childbirth at a health clinic, we can't get the body back in time to bury it in a custom with Islamic tradition. This program here is increasing the rate of hospital births, because if women are registered and they have an ID card, the family gets the body back faster so they can bury it faster. So it's sort of a crazy way around, decreasing maternal mortality. And of course, women, again, who have births in a hospital birth center are 4 times less likely to die in childbirth, so that's just an added bonus. This is a young Pakistani girl with her baby. She's 16 in this picture. She lives near the Afghani border, and she came to a training to learn how to be a birth attendant for her community. She had her baby home alone in her in-laws' home, and she was not allowed to seek care for that birth because the one health official that they had working in their valley was a man, and so that was out of the question for her to go have a baby with him. So she had her baby at home alone. A lot of countries in the world do not allow women to seek birth contraception or care without the approval of their families. Even in Morocco, which we think of as being a more westernized country, women there do not have the right to say no to their husband for sex. There's no such thing as a man raping his wife. In Pakistan, Afghanistan, women do not even have the right to not be beaten by their husbands. And so when women are potentially the subject to such violence, that cannot be even, they have no resources to go to. There's not even a law that protects them. This definitely increases the rate of maternal mortality because they can't seek contraception, they can't seek care for delivery, prenatal care, and they are at risk of violence during pregnancy. Also probably much higher rates of postpartum depression and suicide postpartum. So I think most people are aware of the fact that if we give women access to contraception, maternal mortality plummets. It's a little bit of women who have access to contraception are less likely to have maternal mortality as well. But here's a study of 172 countries, and this is a logarithmic exponential measure of maternal mortality, and it falls dramatically based on what % of the women have access to contraception who want contraception. UNESCO is not UNESCO, UNFPA is a population fund, is an arm of the World Health Organization, again, same member countries, although some member countries are much more involved in this than others. They are really in charge of gynecology, OB gynecology for the world. They look at family planning, they look at safe delivery, and they've been very active in getting some countries to adopt better contraception policies. Ethiopia has been a large target for the World Health Organization, the Gates Foundation, UNFPA, and other organizations working on healthcare because they had even up to 2005, they had such poor rates of a lot of the MDG, the Millennium Development Goals outcomes. Just looking at 7 years between 2005 and 2012, obviously not just looking at contraception, but looking at a multi-organization, multi-government approach, Ethiopia has made dramatic improvements in their health care. One of the ways they've done this, though, is with UNFPA working very heavily in that country to provide contraception to women who want contraception. And just, again, looking at a 5-year range here, they were able to help increase the contraception rates from 13 to 32% and basically end contraceptive shortages. So around the world, where I work in Bolivia and Ethiopia, it's the same. The public health system has contraception. They have birth control pills, Depo-Provera shots, IUDs, but women have to walk to those clinics to get their contraception, and oftentimes when they get to the clinics, there is no contraception available. Oh, sorry, we ran out of birth control pills last month. Maybe we'll get some next month. Birth control pills do not work very well if you only take them every other month. In Bolivia, they will only dispense 1 month of birth control pills at a time, even if you walked 8 hours to get to that clinic. They will dispense 10 condoms at a time if you show up with your partner. So there are lots of these barriers that really restrict contraceptive use, even though it may be provided by the government. So one thing that Ethiopia, or that UNFPA helped Ethiopia do, was to set up a computer system. So they gave them computers and they helped them set up basically a stocking system so that the central government knew when the clinics were out of birth control pills. Pretty simple. So they decreased their shortages from 90% to 0.8% just with a simple computer system. The other thing that Ethiopia has done very effectively is they've trained community health workers. And one of the things that they've trained their community health workers to do is to put in implanons, which is a long-acting progesterone birth control, like a Norplant that goes in the arm. And in just 5 years, they've placed 1.7 million implanons. And this is optional birth control. This is not mandated. So water and sanitation and hygiene, WASH. This is an acronym that's used in a lot of global development programs, and there are some people who feel like if you are an NGO working in a low-income setting, you should have some WASH program, that it's really Any of your other measures that you're doing in terms of development work are spitting in the ocean if somebody doesn't have clean water and sanitation. And I think we're all familiar on how this works, but just to put it up there for a little review, poop gets into fluids, fields, flies, and fingers. It contaminates food, and then the new host gets it, and the cycle goes back again. We can stop this cycle by sanitation, hand washing, and safe water. So how does this affect people in the developing world? Well, 89% of the world now has improved drinking water sources, well, as of 2011. Still, though, 750 million people rely on surface water, which means open water that anybody can poop in, or their animals can poop in, or they can wash their clothes in. And then this girl washes her clothes. The people downstream get that water. She takes some in the house to cook with or drink. Sanitation facts are much worse. 1 billion people, 15%, still practice open defecation, and most of those are in rural areas where the food is grown, and almost 1 billion still used public or shared facilities. I don't know if anybody's used a public or shared facility in a poor income country. You can understand why people use open defecation if that's your choice. So how does this affect maternal mortality? I think we all know about diarrhea and babies. Babies die from diarrhea. Probably 2.3 million babies die a year, in fact, from diarrhea. But mothers also die from diarrhea. And some of the outcomes are why mothers die from not having water and sanitation. If women have to walk a long ways to get water, they're much more likely to be malnourished and anemic. They won't gain as much weight in their pregnancies. And anybody who's malnourished or anemic is more likely to die from a postpartum hemorrhage and from postpartum infections. Also, women without access to sanitation are more likely to die of infections. They're more likely to get hepatitis, parasitic infections, diarrhea, anemia, malnutrition during their pregnancy. And women without access to clean water after childbirth are much more likely to develop postpartum infections and obstetrical fistulas because they can't keep their bottoms clean. Does everybody know what an obstetrical fistula is? No? Obstetrical fistula is when the baby gets stuck gets stuck in the pelvis for a long time and the baby can't pass, and a hole gets made between either the vagina and the rectum or the vagina and the bladder. Then after the baby's out, that hole walls off, so it's a permanent hole, so women just leak urine or leak stool through their vagina. They have no control of stool or urine, so that's a life-altering occurrence when that occurs. And if you can't clean yourself up after you have a baby, you are more likely to have a problem that develops into a fistula. So another thing we talked about in terms of increasing maternal and infant mortality, or maternal mortality, is access to skilled birth attendants. Access to skilled birth attendants does decrease maternal mortality even if birth occurs at home. The World Health Organization feels that the main problem we have right now is the lack of enough skilled birth attendants to provide this service to women around the world. And WHO also estimates these reductions with having a skilled birth attendant in the same location for the birth. So we're not talking about moving people into a hospital. We're still talking about still having them deliver their babies at home, but now with a skilled birth attendant instead of without. And we can have up to a 40% reduction in hemorrhage, a 30% reduction in eclampsia, which is a hypertensive disease in pregnancy. Women die of stroke when they die of eclampsia or hypertensive diseases usually. We can reduce infection by 50%, and we can reduce dystocia by 75%. I should have defined dystocia earlier. Dystocia is when the baby gets stuck. And you think about dystocia as needing to be relieved with a cesarean delivery, but that's actually not the case. Most dystocias, or baby getting stuck, can be relieved with simply position changes, coached pushing, simple episiotomy cutting. You don't need a cesarean most of the time to relieve a dystocia. Talk about a couple countries now that have made huge improvements in their maternal mortality in the last 10 years or more. China has had, and I'll show that on the next slide, an 80% reduction in their maternal mortality since the 1990s. And a lot of that has occurred because of the economic growth in China. China now has a lot more money to spend on healthcare, but they are spending it on healthcare. And China's push is to get women to deliver in hospitals. They are not promoting skilled birth attendants at all. They promote every woman needs to have a birth in a hospital. And one region they showed, and this was a region where they had a 5 times higher rate, they were able, through infrastructure changes, through education, through transportation, a 3% per year reduction in maternal mortality. And again, they felt that in China, hospital delivery is the strongest prediction of a better outcome, and still though poverty and illiteracy are poor outcomes in their country. These are China's numbers. I won't go into this too much. But China has had an 80% reduction in their maternal mortality over the last 20 years, and that accounts for 10% of the world's decline in maternal mortality. And China is a middle income, not a low income country. So even them making this change has reduced, because of the sheer numbers, has resulted in a 10% worldwide. India has approached this problem a lot differently. India does not have the infrastructure to provide hospital births for all of the women. They have some different programs. I cited one program here that they are, oops, typo, they are promoting to get more hospital births, and that is, a lot of countries in the developing world have sort of a 2-tiered health care system. Almost all countries have a free public health system that poor people access, and then most countries also have a private healthcare system that the wealthier people can access. Usually the public healthcare system is, of course, underfunded and understaffed. And so India has used a method of paying their private obstetricians to deliver babies for poor women, and that's worked very well for them. India has also really promoted community health workers in their low-income settings in the urban areas, the slums in India. They're really promoting skilled birth attendants who go to the home, community health workers who do prenatal care for women. And that's been very successful for them. India has 107,000 fewer deaths per year than they used to. And that has accounted for 40% of the worldwide decline in maternal mortality. Now, part of that is just volume because they have so many people, but a lot of that is that they've put out a lot of multi-tiered programs to address maternal mortality, and not just focused on hospital births or just community health workers or just improved nutrition. They've really done the whole thing. So another study from Malawi, and I just mentioned this because it's amazing the power of such minimal impacts in some of these very low income settings. This was a group where they introduced a peer counselor, and so this is sort of a community health worker, but even less trained than a community health worker. This is a woman who is a volunteer from the community who has been trained less than 1 day a month on counseling women in her community. But the peer counseling model is very powerful, and just for 5 visits during pregnancy, they were able to produce a 74% drop in maternal mortality and a 41% drop in infant mortality. And this is mostly through getting women to access a skilled birth attendant. So this was not providing the skilled birth attendant, but it's just educating women that they should access a skilled birth attendant, but also things like nutrition, hand washing, and simple prevention techniques. The low-lying fruit. So overall, in the last almost 25 years now, there has been a huge decline in maternal mortality. It wasn't what the Millennium Development Goals had hoped for. However, it's been very significant. And multi-system approaches tend to be the best for most countries. You need to have people working on this issue from lots of tiers because of all the multiple socioeconomic causes. Building roads and registering women as citizens decreases maternal mortality. It's not just providing antibiotics postpartum or preventing postpartum hemorrhage. Many regions still have very high maternal mortality, and it's sad to see that some of the countries in the world are really having increased maternal mortality in response to conflicts. So I think that this is an interesting quote by Paul Farmer. Does everybody know who Paul Farmer is? Works for Partners in Health in Haiti, and he's really done some great work there over the last 20, 30 years. And I think this reflects the new Millennium Development Goals, that we're not just looking at a 75% reduction, we're looking at all countries to have a 70 per 100,000 death rate, because all women should have access to care, no matter if they're in a low resource setting or not. We should not have the disparity that we're currently seeing. So I'm going to use the rest of the time just to talk about the programs that I'm currently doing with GMEF, Global Midwife Education Foundation in Bolivia. I thought it might be interesting for you young people, maybe your old people too, to see what somebody from Montana can do. You know, it doesn't have to be, you don't have to be living in Washington, D.C. Running a governmental organization to be making changes in other places. This is a picture of a community that I have worked in Bolivia. This is a roadless community near the Altiplano at about 10,000 feet. So the organization I run is a 501c3. It is not that difficult to start your own 501c3. And it does not take more than a few months to do that through some paperwork that you file with the government. And the reason I'm working in Bolivia is Bolivia does have, particularly the region that I'm working in, has one of the highest maternal mortality rates in Latin America. It's Spanish speaking, and it's a safe place to travel. So those were the selection criteria for me. And the programs that we're doing there now are some birth attendant trainings, and going to try and turn that into community health worker trainings in the next couple of years. We have clean water projects, sanitation projects. We train the healthcare that are currently, healthcare workers that are currently working in remote areas, and we work on some contraception programs. And I work very closely with the Ministry of Health there. They share their statistics with us, and so we're able to follow our outcomes. This is a city called Tupiza, and this is where we're based out of. We don't do projects in here except if we do contraception programs at the hospital. We use the hospital here in town, but otherwise we're working in the rural areas around Tupiza. The Ministry of Health was very much interested in starting a program for birth attendants. They have, like a lot of public health systems in remote areas, in low resource settings, they have maybe one health outpost for every 10 to 12 villages. And so that one village in a remote area has a health worker, but everybody else still has to walk to that clinic. And if you are in labor, it really just depends on, you know, if it's too far to walk or not. And so the Ministry of Health was very much in favor of training birth attendants to have a birth attendant in each village, not just the village that had the health outpost. And so they identified women who were traditional birth attendants from each village. And then, so these were more the traditional birth attendants in front, and then the young women who were not traditional birth attendants but are interested in becoming midwives. And they would sign them up. They come into a central area, whether it's Tupiza or the central village, and then we travel out there and we train them in how to deliver, how to perform safe, sterile births. They get a birth kit, and this is typical for other people training birth attendants too. It's basically things to make their hands sterile, bleach for the unclean water they use, soap, sterile hemostats, and scissors to cut the cord. They have sterile ties to tie the cord off, headlamp because often there's no electricity for the birth, a clean towel to dry the baby. And for the half of them that are literate, they do get a book on midwifery in Spanish. For the ones who can't travel to the city to Pisa for training, then we travel out to their region to train them. Often we'll travel with people from the Ministry of Health. This can be a coordinated effort, so it's difficult to raise money for these types of projects, and so you're always very cost conscious. If I cooperate with the Ministry of Health, they will let me use the ambulance. I pay for the gas, which might be $100 to get to the remote areas. They get to send their statisticians to keep track on the outcomes of the community. They might be able to send an educator to help work with the doctor who's in that area. And so it's really these coordination, collaboration that works for rural projects. This again is the type of vehicle we travel in when there's not an ambulance available. And this is where everybody else travels as well from these remote villages. They fill the bottom half with supplies like potatoes and propane tanks and rebar, and then you sit on top of it for an overnight trip to the area where there'll be training. And these are the roads we typically travel on, long, dusty roads. We can't travel during the summer months because of the inaccessibility, the mud. And when we get into the remote areas, we don't know who's going to come to the trainings because the Ministry of Health has set things up. So this is a woman who came. I travel with a Quechua interpreter. And this is a woman who came. She had 4 babies on her own, delivered by her husband, and she was coming to learn to be a birth attendant to serve her community. And as I said, a lot of the population is illiterate, so most of the teaching, if people are illiterate, we focus on hands-on technique, learning to put on gloves, learning to wash your hands, learning to use a clean surface, and we role play over and over again. Everybody in the class has a baby, everybody gets to practice delivering a baby. We go over and over again on the sterile techniques, preventing postpartum hemorrhage, preventing dystocia. And it's very physical, we just learn very differently when we're all literate and we're used to studying books, and so we do a lot of demonstration, demonstrate what is a postpartum hemorrhage, when do you need to start walking to town, what does 250 cc's of blood look like, what does 500 look like, and these type of training techniques. That's Jell-O and Kool-Aid. There's another woman practicing delivering the baby. These are, unless you have very, very big populations to study with maternal mortality, or you have very many years to study the maternal mortality, it's difficult to show good outcomes with birth attendant trainings because even though the rates in these areas are high, 400 deaths per 100,000 births is still not a super high number, so you need a lot to show that you're making an impact. So more we work, I get gratification knowing that these training processes work in other places of the world, similar to where we're working, and we get anecdotal stories. This baby was delivered by one of the birth attendants we trained, and she was a breech presentation who got stuck, and the birth attendant helped relieve the dystocia, the stuckedness. There's not a good non-medical word for dystocia. And then the baby was not breathing. It looked dead. They kept saying, oh, it looked dead. And they did the mouth-to-mouth resuscitation that we taught them in the class. And the little baby, as you can see, came back. So they were very happy with, obviously, the results. So when you start traveling in these areas, you do, I started to see what other people were talking about, that if you don't do anything with water and sanitation, it is, you're not making a full impact. People are living in just total poverty, and if you don't have clean water to drink, it's really hard to expect improved outcomes in maternal mortality. people in these areas were drinking, again, open water sources. Here are some little kids even hauling the water home, learning from a young age. So we've started investing in some water projects. We meet with the communities. There's very much community involvement. We meet with the community. They ring the bell and call everybody in for the community meeting, and we sit down and say, you know, we've heard that you need a water project, or would you like to have bathrooms in your community? And we hear their ideas about how they'd like to do things. And they set timetables, because our projects always involve work from the community. They have to dig holes, or they have to dig canals to put the piping in. And so we always set a timeline with the community. What do you think is realistic for completing this work? There's lots of negotiation. And then once they have the supplies, they act on that timeline. This was a water project that the government of Bolivia had actually funded, but had washed out within 3 months of putting it in because they didn't bury the piping deep enough. And so for $2,000 worth of polytubing, we were able to restore water to this community that hadn't had clean water in over 7 years. And they put in 600 meters of piping in 1 weekend. They get to work. And they had clean water. And we do a lot of bathroom projects with the area that we're working in really has had a 100% open defecation rate. And you can't do too much with your water sources if there's poop everywhere. So we again go to the communities, and now actually communities come to us with the requests to put in bathroom projects. We go out to the communities, we present what the bathroom project looks like, we give them a plan of how to build a bathroom. This is the bathroom that we use. This is a bathroom, a model that obviously we didn't develop. It's used other places around the world, and it is designed to be a permanent solution. People dig 2 pits, and these pits are designed to be big enough for a family of 8 to fill up over 2 to 4 years, each pit. And so they dig 2 pits, they fill the first pit, they move the little plastic bottle that plugs the hole, and then they fill up the other pit. When the other pit's full, it should have been 2 to 4 years since the first one was filled. 2 years is what it takes for the toxic bacteria to become sterile enough to use as fertilizer in a field, rather than for use immediately in the field, which is what open defecation does. And the Ministry of Health and the Sanitarian is involved in this, and they go and teach the communities. They help plan where to put the bathrooms for each home. And then the citizens or the homeowners dig the pits to put the bathrooms in. This woman is actually, though, working on a daycare-like facility. So this isn't for her home, but the community comes out and they put in a few public ones too. Daycares, the health clinics, schools get bathrooms too. So they dig the pit, they line it with rock, and then they put a cement cap so that the rocks don't fall in. And we have bathroom opening ceremonies with yamitas. And then this is what a typical little bathroom looks like, a toilet. You can't see the sink, and there's a little sink for hand washing. We also do trainings, like I said, for the nurses and doctors who work for the Ministry of Health. These are the people who are already working in these remote areas. And one thing we did last fall was to teach, we taught a lecture on eclampsia, or again, when women die of stroke, and how to prevent that. And then we taught another course on newborn resuscitation, and brought down these little ambu bags to resuscitate a baby. About 5% of babies don't start breathing after birth, and they need a little help to get going. And if you don't know how to do it, they'll die. You can just give them simple mouth-to-mouth resuscitation, but that increases the risk of complications and pneumonia. And so we dispense these little bags. Does everybody know how those work? You just make a seal and push air into the baby's lungs, and it jump starts them. They start breathing. These bags are reusable. They're made by a Scandinavian company who distributes them throughout the low-income countries. And they're about $25 a piece, and they last for years and years. We also do tubal ligations. That was a program that was very difficult to start through the Ministry of Health because of strained relations between the United States and Bolivia, but after a couple years of negotiations, we're able to offer this to women who want permanent birth control, because if we talked about the challenges of temporary birth control in the rural areas, makes it very difficult. Permanent birth control is a nice solution for women who have completed childbearing. They come into the hospital in Tupiza. We do a preoperative visit, screen them for diseases and pregnancy, and pay for their hotel the night before. They get the sterilization the next day at the hospital, and then they stay one night in the hospital, and then we pay for their transportation to go home. Here's a mom who just had a tubal ligation with her fifth baby. She had actually 3 babies starved to death due to her own malnutrition. So in the last 3 years, our organization has trained 143 birth attendants. We've trained 43 Ministry of Health nurses, provided long-term contraception, built over 450 bathrooms, and completed clean water projects in 3 communities. And our operating budget is about $30,000 to $40,000 a year. This is Guadalupe. This is a community that's probably going to get bathrooms next year, depending on funding. So, okay, good. So I ended with time for questions. Yep.
I'll try to be short. So I take it, have you ever had to, have you maybe done like maybe a life, or have you ever given a birth while you were there working? Mm-hmm. And what is that like compared to maybe like, is it?
It's terrifying. It's absolutely terrifying. I can't stand it. I don't like to be at those births. There's nothing you can do if something goes wrong. I can teach it for those people, but boy, I don't want to be there. There's really nothing you can do. I mean, it's all prevention. If something bad happens, So it's important for training these people because this is the setting that they work in, but for somebody who's used to working in a hospital setting, it's...
And then for women in India, what's the application process like to get private obstetricians to come to them?
Well, it's like a voucher. So so the obstetricians don't go to their house. They get a voucher from the government, and I think they have to have some income verification that they're low income, and then they're provided a voucher from their public health where they would usually go, and they take their voucher to the obstetrician's office, and that obstetrician then takes the voucher and then later bills the government back for that. Yeah. So that's how that works. Yeah. Yeah.
The sanitation system that you showed is fairly complex, especially since it needs water.
Yeah.
Have you looked at any of the systems that don't use water?
We have looked at the systems that don't use water. There are not too many communities left in where we're working that don't have water still. And the problems with the systems that don't use water is people don't like them. Composting toilets, you have to empty out the poop every time you use it or once a week, and nobody likes doing that. And the pit toilets, they get full and then nobody wants to use them. And so we really haven't done that. I mean, I know they're an option. We try and find, so that bathroom that I showed you with a ceramic toilet and a sink, a roof, cement floor, costs about $150 in supplies to build. And we are asking people for a major behavioral change. And so we're asking them to stop pooping where they've pooped all of their lives and to start pooping inside. And in order to make that behavioral change, which is difficult for all of us to make behavioral changes, right? I mean, I just try not to have my Diet Coke at 3 p.m. every day. That's difficult enough. To ask me to poop somewhere different, you need to give them a nice bathroom, and they like the bathrooms that we're giving them and they're using them. Yeah.
So
So you talked about training women to be birth attendants. Do you ever train men?
Yeah, that one slide I showed, I forgot to comment on that. The birth attendants are at least 30%. I think it's more like 40% men in Bolivia, which is really interesting. And this one region I went to, they were all men. And that was just sort of the way it was. They were all men. And it's accepted in that culture. So I think in other cultures that would be, you know, in Islamic cultures that would not at all be accepted. But in Bolivia, for whatever reason, I was a little uncomfortable with it, to be honest, at first. I was like, really? But they were very engaged and excited about it. And as a benefit, a lot of the men have been better educated. And so it was easier to teach them. They could read the books. And not that I'm promoting, you know, one gender over the other, but it was easier to teach somebody who had a better education. Yeah.
I know you said that the government wasn't like, they weren't too receptive to the idea of doing tubal ligations at first, but were the people, the Bolivian people themselves, really receptive to your teaching and like your ideas, like the new, like the little like masks?
Oh yeah, they're very receptive, and the government was not receptive. There's a lot of anti-Americanism in Bolivia currently. We funded the opposition to the current president when he was running for election. We funded the political opposition, and so after the election, the current president kicked out USAID from the country, and then I think they kicked out our ambassador, and then we came back by kicking out their ambassador. So right now there are no formal relations between the two countries. And so there's a little skepticism, you know, this American just wants to come in and sterilize everybody. But after you know, work in a community and you build that trust and that relationship, you know, and women want contraception. They all tell you, Bolivians breed like rabbits. They always say that. And we want contraception. Yeah, so. Yeah.
Is it easier for your organization to maintain relationships that you have because you have them over years and years in Bolivia now?
Oh, definitely.
Okay.
Definitely. I'm going to try and start up a new project in Peru this year. I got funding specifically for Peru. And it's, you know, I'm not looking forward to going in and meeting everybody and trying to, you know, convince them that you're trustworthy. It's definitely, just like anything you do, it's really all about the relationships and the people that you're working with. And if you don't have those relationships, it's hard to get things started. But I think we can use the credibility of what we're doing in Bolivia, and I have nice letters from the people in Bolivia that'll, you know, introduce me. Yeah.
So they want contraception, but I was going to ask you, do you feel you've been able to impact the extremes of maternal age, either the very young or the old, as a cultural factor that bears on the maternal mortality?
You know, I think the extremely young is really going to be impacted mostly by education that occurs in the school, and we definitely talk with the government about sex ed in the schools. That is not something that is a cultural norm at this point in the schools. The schools are public, but they're still very much Catholicism. We lived in Bolivia for a year. My sons went to school there, public school, and they came at home and said, you know, there are 3 types of organisms. There's animals, plants, and humans. It's still very Christian, Catholic-based education, but I think that Bolivia is moving more forward with reproductive rights for women and more education, and I think that's where you're going to impact the young. You know, is getting more of that. I think where you're going to impact the old is with contraception, the older moms, because those are the moms who often die of the preeclampsia, are the moms that are 35. Last year in this town, or the region I was working with, 2 women died in childbirth, and both of them died of hypertensive diseases. Both of them were in their 30s and already had 4 or 5 kids at home. That death has a huge downstream impact. Not that the death of a 14-year-old first-time mom doesn't have a big impact, but when a 35-year-old mom dies with 5 kids at home, puts those kids at huge risk for early childbearing themselves, extreme poverty, all kinds of things, as you know. And I think that permanent contraception, either vasectomy, tubal ligation, or semi-permanent contraception with an IUD are really appropriate for women who feel they've completed their childbearing desires. Yep.
So when the wife decides to do the contraception, like what is the etiquette of their husband?
Well, they don't come in unless they have approval of their husbands. And that was actually something we negotiated with the government, is one of the criteria is that it has to be signed off on by the husband.
So what's the general attitude of the husbands about contraception?
They are in favor of contraception when they feel like they've had enough babies. And I think the ideal family size in Bolivia, in a lot of these poor settings, is going to be much larger than our ideal family size. But they still reach that ideal family size, and then they want to be done. Yeah, both the men and the women. And sometimes it's actually the men who really want their wives to have contraception, but the women are fearful. They don't want to have the contraception. Oh, sorry.
Earlier you said the rate of maternal mortality in the U.S. is really increased. Could you expand on why that is?
I think that's a big question that a lot of people are working on. Montana just recently formed a maternal mortality commission through our state, and a lot of states are forming those commissions. I think what a lot of experts on public health and epidemiology would agree that it probably has something to do with the increasing disparity in our country. Poor have gotten poorer, they're getting less health care, while the wealthy are smaller in number now, but are monopolizing more of the healthcare dollars.
Does your foundation have any interest in any ability to use students as interns or volunteers in any way?
I have a lot of people ask me for if they could volunteer, but one of the things that they would have to do to volunteer would be to be Spanish speaking, because there's no English spoken, and so I haven't had anybody who's sort of followed through and ended up being Spanish speaking and then willing to travel, but I certainly could put a student to work, even just like in data collection about what people would like. What I'm thinking about now is doing some kind of survey of studying these communities, what they want from a community health worker, what would be the community's ideal of a community health worker. So I need somebody to go and visit these very remote areas who speak Spanish.
Yeah. What do you bring back to your own practice and to your own daily life from doing your work abroad?
It's always really difficult, actually, to come back from being abroad. I feel like I do more the other way, but I think patience. I bring patience back from working abroad, and that may sound backwards, but get so used to waiting in a developing world. I think that it makes you much more of a patient person. I'm not a naturally patient person, so something I appreciate from working. Yeah.
So do most of these villages speak Spanish or Quechua?
Most of them speak Spanish. Yep, most of them speak Spanish. They're in the Altiplano when you get up very high, 13,000, 14,000 feet, that region. They speak Quechua, although the younger people are learning Spanish. The Spanish is what's taught in the school.
Okay.
Yeah.
How did you get to the roadless community? You never mentioned that.
Walk.
How long is the walk?
Oh, usually you can get to like the end of the road, and if you can get to the end of the road, it might be a 30-minute walk. Yeah. In one community, we put toilets into a roadless community that they did have piped water, and the donkeys carried the toilets in to that roadless community. Yeah.
Well, I certainly appreciate you coming here and sharing these insights and this wonderful work that you've done for the foundation. And I think what I especially appreciated was the great detail that you shared with us. I learned a lot about some of the detail that you've found in your work in Bolivia. So let's give a special round of applause.